We're back on this Saturday morning. Steve Cashel, Dr. Brian Cole. It is Sports Medicine Weekly. Our producer, Shane Reardon, our coordinating producer, Teresa Ann Seeger. Time now for our Ask the Doctor segment. You go to our website, sportsmedicineweekly.com. On our homepage on the right side, underneath our picture, you can click on a link. It says Ask the Doctor. Submit your question here. And we've got a number of questions in. We thank the people listening for participating. Doc, I've got the first one right here saying, I have a bone-on-bone arthritic shoulder, dominant arm side. I'm 55 years old, very active and fit. Is that too young for a shoulder replacement, which is being recommended?
No. So great question, and it's an area of particular interest of mine because I really enjoy taking care of young patients who have arthritis. In fact, a big part of my career has been dedicated towards finding alternatives to joint replacements. And the reason we're looking for alternatives is because when someone is very young, their lifespan, their natural lifespan, will outlive that of the implant or the prosthesis, and it may loosen over time. Truth be told, 55 is probably not too young, but I think what's more important, what I tell patients is that if a joint replacement is the right solution, the time to do it is when it's sort of inversely related to the misery factor. You know, you can't use age as a sole determinant should you or shouldn't you have a replacement.
Right.
If there's no good solution and your condition doesn't have, good alternatives that are non-replacement related, and you're miserable, you can't sleep, you can't be active, then you replace it and you deal with the consequences of a joint failing, if you will, 10, 12, 15 years down the road. But 55 is a good age. Are there alternatives? Yeah. I mean, this individual has to make sure that he or she who has shoulder arthritis has exhausted non-surgical care. And that means injections and physical therapy typically, and sometimes oral anti-inflammatories, a Motrin-type drug, if you will. And if that's effective in reducing the symptoms and improving function to a level that they can tolerate and is acceptable, even though it's not perfect, then they stay the course. But if the non-surgical treatment doesn't work and the level of pain and impairment is just something that they don't want to tolerate, then surgery is an option. And it's not always a replacement. For some people, we do transplants in the shoulder. They're usually much younger than a 55-year-old. But for others, we go in and do a clean-out. We go and release the capsule. We improve the range of motion, get rid of bone spurs. And that can be very effective put people in a holding pattern for 2, 3, 4, 5 years before they need the inevitable joint replacement. So it's not too young, but you have to really match the solution to the problem, and that's what's really important in general for any condition that we're treating.
Let me follow up with one of my own, okay? This is me. We've talked about my shoulder. I went to Midwest Orthopedics at Rush, and you guys gave me a cortisone shot, and much better, and I was doing some physical therapy. Hadn't needed it, but you know what's interesting? I can lift weights, and I can't go over the limit, but I'm okay with it. I can pitch batting practice. I can throw a football. I can play golf without any pain. But, Doc, when I shoot a basketball, ouch. I cannot shoot a basketball.
Right.
Why?
So you're right-handed,
Yes.
and it's your right shoulder.
Yes.
So with basketball, you're shooting with your arm at shoulder level or above.
Yes.
And I think your diagnosis, if I remember when I treated you, was rotator cuff tendonitis. And that's why the injection worked, because it's delivered in the place between the muscle tendon area, the rotator cuff, and the bony roof called the acromion. So we put it in the space there that just bathes it to get rid of the inflammation. And that space is impinged on, if you will, when your arm goes above your shoulder. That's why rehab is so important, because if you strengthen your shoulder blade, you're less likely to have abnormal motion around the shoulder when your arm gets to 90 degrees or above. And we all think, well, I need more rotator cuff strengthening. The reality is you need scapular or shoulder blade strengthening so that when you do overt activity such as basketball, not golf, basketball, you can get rid of that pain that you're experiencing.
But I'm thinking, I'm throwing a baseball similar. I'm throwing a football
I'm
similar.
surprised you
why
don't.
When I go, and we're in a radio studio,
Yeah.
but I'm looking like I'm making a shot, but oh my goodness.
Yeah, because the shot is different. Right. You're going vertically up in the air and you're following through, and then you're using your muscles to slow it down. But truth be told, I'm a bit surprised that throwing a baseball doesn't bother you.
After a while it does, and I'll feel it the next day,
Right.
But doing the motion, basketball, I'll take 2 shots and go, I can't do this anymore.
I understand.
It hurts.
I understand.
When would I be in line for another cortisone shot?
So cortisone you can give to a specific area we say up to 3 times a year. Now, it's interesting. There's not a lot of science in that. That largely came from the small joints of the hand when people had rheumatoid arthritis, which is now treated by oral medications.
Okay.
And there was some conditions of instability and things like that would develop in the small joints. But that's been sort of extrapolated to large joints like the shoulder, where we say 3, max 4 a year. But, I don't want to keep injecting a patient if they're not getting the response. In my mind, it's not even worth it if you're not getting more than 3 months, And I wouldn't do it in perpetuity. At some point, I'd say, look, it's working short term. We got to come up with a different strategy. And that's if you have a surgery that predictably gets rid of the problem. I'm not advocating surgery for you.
Right.
But if at some point, if you needed repeated injections, you're just tired of living with it, a surgery can resolve it. And it's not a difficult recovery.
So no side or after effects of the cortisone shot. It's just you don't want to do it repetitively.
Well,
right?
there is some science that suggests, for example, that doing a joint replacement, for example, in the knee within 3 months of a cortisone injection could be associated with an increased chance of infection. Very small, but it's possible. Similarly, in the shoulder, there's some data, maybe 1 or 2 studies that suggest it could be a risk factor if surgery is done in close proximity to giving a cortisone injection. In my experience, I haven't seen it. Are there papers reporting it? Yeah, there are a couple papers that discuss it, but I haven't seen it in the course of my practice over 23 years.
Okay, next question, because we're running out of time, and coming up next on the Score, Inside the Clubhouse with Bruce Levine, talking baseball. Here's your question, Dr. Cole, in our Ask the Doc segment. I'm trying to rehab a persistent IT injury through massage therapy with no success. What do you suggest?
Well, IT is the iliotibial band. The other name is iliotibial band friction syndrome or runner's knee. And what happens is individuals will complain of, after running for prolonged periods of time, very sharp discomfort on the outer side of the knee without any swelling. And therapy is the mainstay, but modifying shoe wear, changing their running. I see this in people who are training for the marathon who are upping their running mileage, or they're changing where they run. If they run on ramped or inclined surfaces, they start to get this increasing sharp pain with repetitive activity. So IT syndrome is runner's knee. Is not a condition you should run through, but you can run to it. If you try to run through it, it just keeps it around much longer. Ice is incredibly important. Physical therapy is very, very helpful. Stretching before you run. Sometimes injections into the area can be particularly helpful, and making sure you have proper shoe wear, going to a good shoe place that can analyze your alignment to make sure that you've got the proper set of shoes. Those are all things that we do for runner's knee or iliotibial band syndrome.
And when you hear of massage therapy, what do you think of what?
It's not my first choice for this condition, to be quite honest. I mean, there are things you can do to stimulate some healing, what we call Rolfing, or things that can use, very firm techniques, but it's not classic massage therapy.
Doc, here's our final question of the show. This person asking and saying, I have a sciatic nerve problem running from my left buttock to my left knee. Aggravated it from not stretching enough before a round of golf. Then I picked up my wife from the floor. She has MS. What stretches can I do, Dr. Cole, at home? What kind of physician do you recommend I see? Thanks. I'm in a lot of pain. Hurts to just sit down.
Well, I hope this listener has the opportunity to hear my answer about their sciatica, because, one, being a caretaker for someone is a huge responsibility, and it's like it's an occupational hazard, if you will, if they get symptoms of nerve pain and so forth while lifting. So, who would you see? There's many individuals who can manage an acute onset of sciatica, which is when the nerves that go across the gluteal or buttock region that go down in the leg get inflamed, and they can cause this lancing, very awful nerve-like symptom. Typically, physical therapy is deployed, which works on hamstring stretching program, core strengthening, pelvic tilts, things like that. Anti-inflammatory, sometimes a steroid or what we call a Medrol dose pack can be particularly helpful, but it almost always resolves with non-surgical care. In the event that there's a structural problem, sometimes injections like an epidural can be particularly useful. But this person should get help soon, because obviously there's someone else who really depends upon their well-being, and I hope they hear this on the show.
Great stuff. Okay, we're out of time for this edition of Sports Medicine Weekly. Many thanks to our producer, Shane Reardon. Our coordinating producer is Teresa Ann Seeger. Many thanks to Dr. Brian Cole's father, David Cole, for managing the website. Also, to Samantha Smith from Midwest Orthopedics at Rush. Coming up next here on The Score, Inside the Clubhouse with Bruce Levine. For Dr. Brian Cole, I'm Steve Cashel. Thanks for listening to Sports Medicine Weekly, only on
670.